Hello everyone, my name is Ryan Steele and I will be presenting a literature critique on the article entitled Vulnerability to the Cardiovascular Effects of Ambient Heat in U.S. Cities. This article was originally published in the Journal of Epidemiology in November 2018. The issue of climate change has been increasingly prevalent in both the academic literature and worldwide media for a number of years now. With climate change, average worldwide temperatures are known to be increasing. It is known that certain subsets of the population are affected by heat-related health events and are therefore more susceptible to this increase in average temperature. Previous research has shown associations between adverse health effects to heat with a number of individual characteristics, including marriage status, medication use, the use of air conditioning, and among others. However, prior research does not include information from a large population-based study regarding how those individual characteristics modify associations of heat exposure with early vital sign changes. There's a need for research regarding which populations are at risk, how they are at risk, and what can be done to decrease their risk of negative health effects related to heat stress. The study objectives in this article are twofold. The first is to assess whether heat is associated with increased heart rate and decreased blood pressure when controlling for age, time, season, and daily ozone and daily particulate matter levels. The second is to assess if these associations differ by antihypertensive medication use, renal function, fasting glucose, emotional support, air conditioning ownership and use, normalized difference, vegetation index, neighborhood safety, and resident-specific oxides of nitrogen and particulate matter. The data collected for this investigation came from participants of the multi-ethnic study of atherosclerosis, or the MESA study. Additionally, temperature data was obtained from the National Climatic Data Center for 8 community stations. Daily particulate matter and ozone levels were obtained from the EPA air quality systems. Overall, data collection for this study seems to be complete and well thought out. Use of existing data can be a useful tool in ensuring that you create a large study population, as these authors clearly did. Quite a few outcomes were measured during the study. Primary outcomes could be split into two different categories: health outcomes data and exposure data. Health outcomes data included heart rate, systolic blood pressure, diastolic blood pressure, glomerular filtration rate, or GFR, which is a measurement of renal function, fasting glucose, body mass index, level of physical activity, and levels of emotional support. Exposure data included mean temperature for the day before and the day of the physical exam, median normalized vegetation index in the participant's neighborhood. The vegetarian index is a calculation of the amount of vegetation around a particular person's house. Additionally, neighborhood safety was recorded using a survey. Secondary outcomes included potential confounding factors, including ozone levels and particulate matter levels. This study was a population-based retrospective cohort study. The MESA study, where the data was derived from, is a medical research study involving 6,814 men and women aged 45 to 84 years from 6 cities in the United States. It was initially designed to study the characteristics of subclinical cardiovascular disease and the risk factors to predict progression to clinically overt cardiovascular disease. Data on these patients was collected during 5 different physical exams from 2000 to 2010. Our study population included initial records from 6,814 men and women aged 45 to 84. Due to discrepancies in the information available, 4,533 records were used. Again, these records were obtained from the years 2000 to 2010 and came from physical examinations from the 6 major U.S. cities. The measures of outcomes and exposures were recorded as means and standard deviations for all of the health outcomes data, including changes in heart rate, systolic blood pressure, and diastolic blood pressure. Means and standard deviations for all of the exposures data was recorded as well. The statistical stability was calculated using a 95% confidence interval. P-values were utilized to determine statistical significance. The statistical analysis used in this paper is extremely complex, and I'll admit that most of it went over my head. I'm not sure if the authors did a great job of explaining their methodology in a clear and concise manner. I personally would have liked to see a more complete explanation of the reasoning for their choice of statistical analysis and possibly further explaining exactly how it pertained to the data available. This slide and the next 3 slides contain 3 tables and 1 figure from the results section of the study. I'll briefly highlight what is important in each one, but I suggest that you go back and pause the video to fully analyze each slide. The tables are very dense, not very well spaced, and sometimes difficult to read. I would have liked to see more organized presentation of the data that was collected. The first table represents means and standard deviations of outcomes and exposures across all of the visit sites. Notice in the left-hand column that there were 18 different outcomes that were analyzed. Winston-Salem had the highest 75th percentile of temperature and the highest AC usage. New York had the lowest percentage of patients who own central air conditioning. Los Angeles had the highest mean level of particulate matter. This slide shows correlations among the means of potential effect modifiers. This table shows changes in heart rate, systolic blood pressure, and diastolic blood pressure for 2-degree increases in daily mean temperatures. Of note, no association between heart rate and warm temperature was observed in any of the models for either category of antihypertension medication use. Overall association between systolic blood pressure and warm temperatures was stronger among individuals taking antihypertensive medications. However, effect modification was found to be associated with other factors only in the patients who did not take any antihypertensive medication. All of these factors are shown in this figure. Factors that had a significant impact on heart rate and blood pressure included GFR and social support. Individuals with worse GFR experienced larger increases in heart rate and decreases in blood pressure. Individuals with worse social support seemed to have attenuated decreases in blood pressure and were lower in number. However, it should be noted that the effect modification results from these factors were eliminated after multiple hypothesis correction. The most significant result involved the ownership of central air conditioning. Individuals with central air conditioning, and therefore assumed to have less heat exposure, were associated with a larger decrease in systolic blood pressure than individuals without central air conditioning. The authors did take time to mention the strengths and limitations of the study. Strengths included information regarding air conditioning ownership that was available at an individual level. This information is not available in other studies and can be a significant confounder if not taken into account. However, a limitation of this study is that information regarding temperature of the examination room at the time of examination is not available. This could be a potential confounder given that the examination is exactly when the data is collected. The conclusions of the study were not always what the authors hypothesized. For example, changes in heart rate were not associated with heat exposure in any of the categories of the effect modifiers. They did find that systolic blood pressure is inversely associated with warm temperature, which is a known medical phenomenon. However, I think that the most important finding is that central air conditioning was the only consistent effect modifier. Individuals without air conditioning showed smaller levels of decreased systolic blood pressure on hot days than individuals who do have air conditioning. One possible explanation that the authors mentioned is that individuals without air conditioning may be better adapted to high temperatures and may therefore have less pronounced decreases in blood pressure in response to warm temperatures compared than individuals who do have air conditioning, who are typically sheltered from the exposure. The authors mentioned that this is an important interaction that's worth further studying. Overall, the authors did a good job of discussing the limitations and conclusions of their study. The discussion section was noticeably brief when compared to the rest of the manuscript, but this may be expected when only one significant conclusion is drawn. I did appreciate that the authors took the time to mention that further study should take place to better define what can be done with the conclusions that they did draw. Thank you for listening to my presentation. This is a really dense study with quite a bit of information available, so please feel free to ask any questions that you may have. Thanks.